Good morning, everybody. I'd like to welcome all of you in our first lecture in Forensic Medicine Toxicology Department. I will be with you during this lecture and the next two lectures in General Toxicology. I'm Dr. Dahab Wahab El-Morsi, Professor of Forensic Medicine and Clinical Toxicology. By our ILOs during this lecture to know the definition of poison, uh, how to classify poison, and the factors affecting severity of poison, and how to reach a diagnosis of toxic patients. First, let us start with the difference between poison and toxin. Is there a difference between poison and toxin? Sure, there is difference between both. Poison is the man-made substance or any substance cause injury through chemical means. So any substance which is man-made or chemical in nature, like household product, like medications, pesticides, all of these substances are man-made and they produce its action by chemical effect, so it is called poison. While a toxin is produced by living organisms, either plants or animals or bacteria or fungi, so it is naturally occurring. So this is the difference between poison and the toxin. But during our lectures, we will use both alternative to each other without focus on the meaning of poison or toxin. First of all, the definition of the poison is a substance which introduced into the living body in a small dose and will produce ill health or even death. What about the classification of the poison? We have actual different classification of the poisons. Some classify poison according to the target organ. We know that when we take a certain substance or certain drug, after it will expose to the pharmacokinetics and lead to absorption and then metabolism and go to the target organ to do its toxic action or its effect, and then will be excreted from the body. So each drug or substance will have a target organ. So they classify the poison according its target organ. Like, for example, acetaminophen or paracetamol, it is a hepatotoxic, mainly acting on the liver. For digoxin, it is classified as a cardiotoxic. Its main action will be on the heart. For heavy metals will be nephrotoxic, toxic action will be on the kidney and so on. But actually by this classification, some poisons have a multiple effect, have a cardiotoxic and nephrotoxic and immunotoxic effect. So this classification will not very accurate. So some scientists make another classification. Scientists choose another classification, which is the chemical nature of the substance. Either the substance is acidic in nature or alkaline nature, and this will help in treatment of this substance. When someone takes salicylate, for example, which is acidic in nature, we will make alkalinization of the urine and change the urinary pH to alkaline. Alkalinization of the urine will increase the ionization of the salicylate, and the ionized form will not be reabsorbed from the renal tubule, so it will be excreted from the body, and this is called ion trapping. The same when someone comes with the alkaline ingestion like amphetamine. So we will make acidification of the urine to help ionization of the amphetamine, and the ionized form will not be reabsorbed, it will be excreted in the urine, and this is known as the ion trapping inside the renal tubule. But we don't know the nature of most of all substances. Some substances are neutral, uh, not acidic and not alkaline. So this classification will be a difficult one. This is the classification that we use, which is a classification according to the mode of action, to the effect, or to the nature of the action, or to the action of the substance. Either it is local effect, or remote effect, or double effect. What is the meaning of local effect? That the substance will acting locally only at the site of entry. And the most famous example for the substance or poisons with local toxicity, which is corrosive. And here I meant by corrosive the caustic acid and the caustic alkalis. Caustic acid and caustic alkalis. When someone comes with ingestion of caustic acid or caustic alkali, so the effect will be local effect in the GIT only, without absorption and without systemic manifestation. And so they hold this patient that he will remain conscious till the end, because there is no absorption from the GIT. And again, I mean here with corrosives, which is mineral acids like sulfuric acid, hydrochloric acid, or nitric acid, and caustic alkalis like caustic soda and caustic potash. Okay, this is the local action. The remote action means that the poison will make its effect after absorption from the GIT, and this is the remote effect. The example for poison with remote action are the poison which are or have a plant origin, like opiates like atropine, strychnine, amphetamine, cocaine, nicotine. All these substances will produce its effect after its absorption. Lastly, we have poison which acting by local and remote effect, or we can call it dual effect. And the most famous example for these substances are the heavy metals. Heavy metals like iron, mercury, lead, arsenic are acting by local effect in the GIT and then remote effect after its absorption. So these are the classification of poisons, either by the target organ, or by the nature of the poison, or the most commonly used one, the mode of action. How we can expose the two poison? Yes, we have three methods of exposure: either accidental exposure, and this is very common, especially in children, or by suicidal attempt, or homicidal attempt. So these are the methods that lead to toxicity or poisoning: suicidal, accidental, and we have different factors affecting the action of the poisons. For example, if I give to each one of you one strip of paracetamol, okay? And then we will examine the signs of toxicity. Shall you have the same toxic manifestation? Definitely not. Each one will be presented by different picture according to different factors. So let us think about the factors affecting severity of the toxicity. Yes, we have two main factors. Factors related to the poison itself and factors related to the person himself. Factors related to the poison itself, depending on the amount of the poison. How much did you take from this? Maybe someone take one tablet of paracetamol, someone take two tablets, someone take the whole strap, someone didn't take any pills. Okay, so the dose of the poison is very important to ask your patient about how much did you take from this substance, the dose. Second important factor is the nature of the poison. Either it goes in a liquid form or solid form or gaseous form. And you know that the gaseous form will be more rapidly absorbed than the liquid, and liquid will be absorbed more rapid than the solid form. So this is the second factor, which is the state of the poison. The route of administration. What about the most rapid route of administration, do you think? I could suggest that some one of you said inhalation and others said injection, right? Okay. So the most rapid route of administration of the poison is the inhalation. Why inhalation route? Let us imagine if you take poison by intravenous injection. So it will go with the blood through the superior and inferior vena cava to the right atrium and then to the right ventricle, and from the right ventricle through the pulmonary artery to the lung, and then after oxygenation of the blood it will be come through the pulmonary veins to the left side of the heart, the left atrium, and then to the left ventricle, and then to the aorta, to the systemic circulation. So this is the pathway of we take a substance intravenous. If we have the substance by inhalation, so it will come direct to the lung, and then after oxygenation it will go to the left side of the heart, to the aorta, to the systemic circulation. So we preserve half of the cycle. Okay, so the inhalation route is the most rapid route of administration, followed by intravenous and intramuscular injection. But the difference between both routes are only few minutes or seconds even. Okay? But which is the most common route of administration? Right, it is the oral route. Ingestion is the commonest route of administration. To take it oral, this is the most common, but the most rapid route is the inhalation route. So the factors related to the poison depends on the dose of the poison, the nature of the poison, the route of administration, and lastly the cumulation. If it has a cumulative effect and could be accumulated inside the body, it will lead to chronic toxicity after many months or years. And the most common example for poison with cumulative effect is the heavy metal. So this is the second character of the heavy metal. We said before that it will acting by double effect, local and remote action, and here we said that it has a cumulative effect inside the body. After many years of exposure, the poison, the heavy metal will be deposited and will be present in the hair, in the fingernails, in the teeth, in the gum, and so on. These are the factors related to the poison. We have other factors related to the person himself. Let us think, what are the factors in the person affecting the severity of the poison? First of all, the age. The age will be very, and these are, by the way, these are the routes of exposure. We have inhalation, ingestion, dermal, intravenous. The very slow route of exposure is through skin or derm. The factor related to the patient or to the person himself, first of all, the age of the person. The age of the person is if we have toxic patient with old age and child and adult age. What the patient we should be worried about? Yes, extreme of ages, very young and very old, because in very old patient they have almost a diseased organ. They have a diseased liver, diseased kidney, and so on. And so the organ become not functioning well. and this will lead to and this will affect the toxicokinetics of the poison and affecting the absorption, the excretion, the metabolism of the poison, and so the old age patient will be exposed very easily to a toxic dose even by a small amount of the poison. The same in the children, but with immaturation of the organs, so they will be more vulnerable to toxicity more than the adult. So you should take care of extreme of ages first and then look for the adult age, because the adult most probably will be healthy and we can uh, carry on the toxicity. This is the age. The sex is very important factor. The difference between male and female. If we have male and female with ethanol toxicity, what do you think the severity of toxicity in male or female? In female will be more exposure to toxicity more than the male. Why? Because the female is born with deficiency in alcohol dehydrogenase enzyme. And this enzyme is an enzyme responsible for the metabolism of the parent substance, which is ethanol, to the metabolites, which is acetaldehyde, which is less toxic. So, by deficiency of alcohol dehydrogenase, the female will have the parent substance for a long time more than male, and this will lead to more toxicity than in male. This is about the sex. Besides, some poison is a fat-soluble substance like organophosphate, which is really deposited in the fat and then will be stay long period of longer time more than in male, and this will expose female to more toxic effect than in male. Another factor, genetic factor. Genetic factor like some people will be born by a deficiency or genetic deficiency in cholinesterase enzyme. And this enzyme discovered that it will lead to metabolism of the cocaine substance. So if someone is exposed to cocaine and has a deficiency of cholinesterase enzyme, so it will be toxic to him rather than other one with a normal enzyme. And this is the genetic factor. The state of health, about the general health of the people, and this is we talk about when we talk about extreme of ages. So if you have a patient with paracetamol toxicity and he has a liver disease also, so this is will increase the incidence of toxicity in this patient, and you should take care of him more than other one with healthy liver. And this is a state of health. The condition of the stomach is very important to ask the patient if he take his food or not, because any poison enter the empty stomach will be rapidly absorbed than if the stomach is full. And you should ask about the nature of the food, if they have, if it is fat, it has a fat content or not. So this is the condition of the stomach to ask the patient about his age, about the general health, about the condition of the stomach. Very important. We have three related items, which is our personal hypersensitivity, tolerance, and idiosyncrasy. Do you know the difference between the three terminology? Hypersensitivity is the allergic condition. When someone exposed to certain antigen, it will lead to a hypersensitivity, reaction, and allergy. Like when someone has a hypersensitivity from penicillin. Okay, someone has hypersensitivity and someone didn't have the hypersensitivity to the same substance. Idiosyncrasy is unexpected effect to certain substance. in tramadol. Tramadol is one of opiate derivatives and it is a CNS depressant, but we have patients with convulsant effect, and this is idiosyncrasy effect. Some substance didn't lead to hypersensitivity or allergy, but maybe unexpected effect occur and lead to hypersensitivity in some people. This is the idiosyncrasy. Tolerance means increasing the first dose of substance to reach the same effect. And this is very common in addicts. Addicts increasing the dose each time because he thinks that he will reach to the first feeling of euphoria and talkativeness and and anxiety and so on. So this is the tolerance, and this is wrong because most of the receptors will be saturated by the substance, and even when increasing the dose each time, the dose will not find any empty receptors to act on. So these are the factors affecting the severity of toxicity. Factors related to the poison. We have 4 factors related to the poison: the dose of the poison, the nature of the poison or the state of the poison, and cumulation and route of exposure. And factors related to the patient himself: the age, the sex, general health condition of the stomach, genetic factor, tolerance, idiosyncrasy, and hypersensitivity reaction. Okay, how to diagnose a toxic patient? You have a patient come to you in the toxicology unit. How do you know that this patient is a toxic patient and not other specialty or not other condition? We have, for diagnosis, to have a diagnosis of any patient, you should do 3 things. First, take a full history, make full clinical examination, and then do investigations. So diagnosis equal to history taking, clinical examination, and investigations. Starting by the history. The history, what are the items of history taking? Okay, we have certain items to fulfill the history. First, you should ask about what is called personal history. And what is the personal history? You ask about the name of the patient, the age, education, marital status, number of children, special habits, الجوب بتاع what is his job, residence. You know all about the patient. To be familiar with the patient, when you talk to the patient, you talk with his name, and to know the age of the patient, to know if there is a special habit of the patient, and so on. So this is the first item in the history, which is called the personal history. Then we talk about the complaint of the patient, and complaint should be written in the patient's own word, not in medical terminology. And here you should stress what make you come to the hospital right now. Don't let the patient to tell stories, and most of the story will not relate to the condition. So be specific and be focused on the complaint. What makes you come to the hospital right now? Then in the present history, you should take details about the complaint. When it starts, is the start is acute or gradual? What are the manifestation or the symptoms? And then if he seek advice of medical doctor or went to a hospital, and what the medication he takes if this happen, all about the complaint. Then you ask about the past history. if there is any medical condition or medication he takes or anything like this. And lastly, the family history of there is a similar condition in the family. So this is the item of the history: personal history, complaint, present history, past history, family history. We stress in toxicological history also, beside all these items, we should ask certain questions, starting by W's. What did you take? What? The name of the poison, if you know. Second, how much did you take? The dose of the poison. When did you take? When? And this is will be related to the treatment and specifically to gastric lavage. How did you take it? The route of administration. Where did you take it? The place. With whom? If he was on cafe or in the work or at home or where, and why did you take it? So these are a very important question you should ask to your toxic patient. What did you take? How much did you take? Why did you take? Where? When? With whom? Okay, so that is about the and then we start with second item with the clinical examination. As you know from clinical examination, we have general examination and local examination. General examination to take the patient as a whole without touching him, just by inspection of the patient as a whole to examine the color of the patient or the complexion of the skin, if there is a specific color of the skin, for example, jaundice or cyanosis or pallor. If you smell certain odor from the patient, and we have different poisons with characteristic smell. If there is a certain gait of the patient, staggering gait, for example, in alcohol ingestion, you should look for the conscious level of the patient. If he is conscious or comatose, you should examine the vital signs of the patient. And the vital signs of the patient, we have pulse, blood pressure, respiratory rate, temperature, and lastly they add to them another fifth vital sign, which is the oxygen saturation. Each one of these vital signs, you should know the normal range to know if the patient has normal or abnormal vital signs. And we have different poison with different effect on the vital signs, either lead to tachycardia or bradycardia. Some poison lead to hypertension or hypotension, some leads to tachypnea or paradipnea, and so on. And you will find in the chapter of general toxicology a lot of tables with this collection. Okay, first of all, the pulse or the heart rate of the patient should be from 60 up to 90 beat per minute. Above 100, this is tachycardia. Below 60, this is bradycardia. This is for the pulse. For the blood pressure, we have systole and diastole. The systole will be from 90 up to 145, and the diastole is equal to the pulse or heart rate, millimeter mercury. Above this will be hypertension, below this will be hypotension. About the respiratory rate, it is from 12 to up to 20 cycle per minute. Above this will be tachypnea, below this will be bradypnea. And lastly, the temperature will be 66.6 to 37.3. Above this will be hyperthermia, below this will be hypothermia. And lastly, the oxygen saturation will be from 94 up to 98%. Below this will be hypoxia, which will be manifested clinically by cyanosis of the patient. So this is general examination of the patient. We look for scan, odor, certain odor. Again, when making general examination, you should comment on the condition of the patient, if he is comatose or conscious patient, and if there is convulsion or about the coma, state of prolonged unconsciousness in which the patient cannot be aroused by painful stimuli. This is the this is the definition of coma. How to examine the coma, or how you comment on the patient if it is comatose or not. We have methods to diagnose coma. We have two grades of coma: Reid's scale of coma and Abu scale. Reid's scale is the most difficult and time-consuming than an Abu scale. It depends on examination of 5 parameters, which is the conscious level of the patient, and secondly on the response to pain. But third on the reflex, examination of the reflexes, and the respiration and circulation. And you should remember them in this way. Okay, we have 5 grades of coma in this scale: stage 0, stage 1, stage 2, stage 3, stage 4. Stage 0 means that all the 5 parameters are intact. The patient is conscious and responds to pain, and reflexes intact with good respiration and circulation. With each stage, we will lose one of these 5 parameters. So in stage 1, the patient is not conscious but still responds to pain and reflexes contact with good respiration and circulation. In stage 2, the patient will be comatose and not responsive to pain, but still have intact reflexes and respiration and circulation. In stage 3, so the patient is not conscious, he is not responding to pain, the reflexes is lost, but the circulation and respiration is intact. And lastly, in stage 4, here all the parameters are lost, but this is don't mean that the patient is quiet. We have abnormal respiration and circulation and need support. Okay, so this is the Reid scale, and as you see, it has a very difficult parameters. One like reflexes intact, you should examine all the reflexes, and this need a long time to finish it. So this scale is not used mainly, if I at least in the EO. Another rapid and very common scale, which is the AVBO scale. AVBO scale. Each letter of these will diagnose certain stage. A for alert. The patient is alert, is a conscious patient. And when we diagnose someone that he is alert, if he can respond to place, time, and people. So if you ask the patient who you are, he knows that you are the doctor. If you ask the patient where he are, he knows that you are in the hospital. If you ask the patient what is the day today, he knows that we are at Saturday and we are at the morning, not in the evening. So if the patient responds to all these questions, the patient, the people, the time, and the place, so he is alert. A. Okay, if you talk to the patient and the patient is not responding to you, and you start by raising your voice to make him uh, respond, and he look to your voice or make certain movement, so the patient is responding to verbal command. This is the second, which is V. Respond to verbal command, and this response either by making attention to your voice or by moving his lamp or his face or his eyes or whatever. If the patient you talk to him, he didn't talk, and you raise your voice and started to make him um, look to you, and there is no response, then you start to make a painful stimulus. And the painful stimulus here is not by beating the patient or pinching the patient, only by your knuckles of the fingers on his sternum or by your thumb on the supraorbital region. We didn't want to make him awake. We wanted to examine his response. So by your knuckles of the fingers of the sternum or by the thumb on the supraorbital region, and then look for the response. If there is response, so he is response to pain. No response, so he is unresponsive, and this is the fourth grade of coma. These are the AVO scale, and as you see, it is very simple and very rapid and not a time consuming, and you can do in few seconds. Alert, respond to verbal command, respond to pain, on response. Sure, we have another scale, which is the Glasgow scale, which depending on the verbal examination and motor examination and eye response, but this is very complicated some and need more practice. And we have a very different causes of coma. We have toxic causes, traumatic causes, pathological, environmental, historical. So you should differentiate between different causes of coma. Very important item in coma is the treatment of coma. And in the treatment of coma, we have what is called coma cocktail. From this name, you know, cocktail means a mix of different substances, okay? So we have three items in the coma cocktail. We have thiamine, which is vitamin B1. We have naloxone or Narcan, which is opiate antidote. We have dextrose fluid. So if the patient is coming with coma, we can use the coma cocktail even if the cause of coma is not opiate toxicity. Dextrose, we use 25% for children and 50% for adults. We have thiamine 100 milligram AIV because if the patient is alcohol toxicity, alcohol known to make thiamine deficiency, so we give thiamine. And naloxone or Narcan, and this is the antidote of opiate, but we can use it for any other cause of coma because it will lead to stimulation of the respiratory system and CNS. The dose of naloxone is 0.1 milligram per kg in children, and in adult will be 0.4 milligram, could be repeated up to 3 milligram total dose. Okay, this is the coma. And this is the AFO scale: alert, verbal stimuli, respond to verbal, then making painful stimulus. If he responds, يبقى response to pain. Unresponsive يبقى U, which is on. The convulsion. This is another item which is very important in the general examination to make a diagnosis if there is convulsion or not. And there are different causes of convulsion. But if the patient convulses, you should control convulsion first to can perform gastric lavage. Control of convulsion very commonly by diazepam, which is benzodiazepine. This is the general examination. So in the examination, we talk about general examination, vital signs, coma, convulsion, smell, gait, and so on. And one of the most important items in general examination also is to make pupils examination. What you should examine in the pupil, you should examine the size of the pupils, either it is normal or constricted or dilated. the reaction of the pupil to the light, either it is reactive or not reactive, and then the equality of both pupils. And you should know by heart that there is no poison can lead to unequal size of the pupil. There is never ever poison leads to unequal size of the pupil. Unequal size of the pupil equal CNS lesion, either trauma, either bleeding, abscess, tumor, and so on. Any space of lesion. Okay, after general examination, we will make local examination. Do you know what is the local examination, or how do you perform local examination of any system? Local examination contains different four steps. Looking by the eye, your eye, examination by your eyes, which is called inspection. And then using your hand, you do two items, palpation and percussion. And then lastly, by your stethoscope, which is called auscultation. So in any local examination of any system, you should perform four steps: inspection, palpation, percussion, auscultation. Okay. So after we talk about examination of the patient, by the way, I said that we have ABCD approach. How do you approach a toxic patient or any other patient? When you approach any patient, you should perform A, B, C, D, E approach. What is the importance of this approach? This approach is treat as you go, and treat first what kills first. And ABCD approach is not arranged alphabetically, A and then B and then C and then D. No, it is arranged according to the priorities. And you should stabilize first the airway, because it will lead to death of the patient before breathing, before circulation. So this is the importance to make a systematic approach with A, B, C, D, E approach. And this is a very, very important approach. You should use it in your clinical life. Okay, so we start by airway, and then after stabilizing the airway, we will go to the breathing, and after stabilization of the breathing, we will go to the circulation, and after this testability, and after this exposure and examination. And as we mentioned, you should treat as you go. If you find anything which is not normal in the airway, you should treat it before go to the breathing, and so on. And treat first what kills first. And by literatures and by researchers, they find that the patient will be died from airway, and then breathing, and then circulation, and then disability. Okay, so this is the systematic approach you should use in your practical life, which is ABCDE approach. What is this approach? You should, in each step of these steps, you should know how to assess and how you treat, and what is the gift you will give to the patient. So start with the airway. You should know how to assess the airway first. To assess the airway, you should talk to the patient. And talk to the patient if the patient is talkative and talk to you. So this means that the airway is patent or airway. So this is the possibilities of the airway to be patent airway, and thank God it is patent. But another patient may come with noisy respiration, noisy sounds, like gurgling, like stridor, like snoring. If you hear any noisy breathing, So this means that the airway is obstructed airway, and this is the second possibility in the airway to be obstructed. And here you should deal with the obstructed airway. How you will deal with the airway? You should open the airway first and then clear and then maintain the airway open. How you will open the airway? The most common cause of obstruction of the airway is falling backward of the tongue. Falling backward of the tongue. When someone is comatose, so the muscles become hypotonic, and loss of muscle tone will lead to relaxation of the muscle, including the tongue. So the base of the tongue will be slivered backward and will cover the epiglottis, and this will lead to obstruction of the airway. So we should open the airway first. طيب, so how to open the airway. We have to maneuver to open the airway. First of all, head tilt, chin lift. As you see in the picture, one hand on the forehead, making tilting of the backward, of the head backward, and two fingers of the other hand on the chin, elevating the chin, or lifting the chin. So this is what is called head tilt, chin lift. To do this maneuver, you should exclude a patient with cervical injury. And how do you suspect that the patient has a cervical injury? Yes, either by motor car accident or falling from a height or box to the head. So if you suspect, until proof otherwise, if you suspect a head or cervical injury, you shouldn't use head tilt chin lift, but you will use jaw thrust. Jaw thrust, you will stand behind the patient, and then by the heel of the palm of your hand, you will fix the maxilla to prevent tilting of the head, and then by the index and the other finger behind the angle of the mandible, and then push forward and upward. This will bring the tongue forward and leave the epiglottis open, and this will open the airway. So this is the maneuver, how to deal with the obstructed airway. First, by opening of the airway, either by head tilt chin lift or jaw thrust. After opening the airway, you should clear the airway. Clearance of the airway will be by making suction of the airway if you have a secretion. And we have two kinds of suction, or two types of suction, either soft suction by gastric tube or solid suction by Yankauer suction. If we have a viscid secretion like blood or vomitus. Okay, type. So after opening the airway and the clearance of the airway, you should maintain the airway open. You should clear your hand, make your hand free to do other examination. So how we can open? By use adjuncts or some devices that will help maintaining the airway open. We have solid adjuncts and we have uh, soft adjuncts. A solid adjuncts, what is called oropharyngeal airway. And as we see, we have different colors of the oropharyngeal airway, and this means we have different sizes of the airway. How we should use the suitable size for the patient? By making sizing from the central incisor of the patient till the angle of the mandible. So this is the size, and this is the pupil size of the patient. We hold it with this concavity upward and then put it above the tongue, and when it couldn't be entered in the mouth, we rotate it for 180 degrees and then introduce it in the mouth, and this will maintain the airway open. This is how we use, or how we will maintaining the airway open. So about the airway again. To assess the airway by talk to the patient. If the patient talkative, means patent airway. If the patient is not talkative, this means the airway is obstructed and we hear a noisy breathing. So you should open the airway by either head tilted chin left or jaw thrust, and then clear the airway and then maintain the airway open by either oropharyngeal or nasopharyngeal. Oropharyngeal airway, this airway should be used if the patient is comatose. If the patient is conscious, he will not tolerate this device. The other one, which is nasopharyngeal airway, and unfortunately you will not see it except in the skill lab. Nasopharyngeal is a rubber tube similar to the endotracheal tube. So in some condition, if we don't have a nasopharyngeal, we can replace it by endotracheal tube and removing the cup and then taking the size of the patient and use it as the nasopharyngeal. Nasopharyngeal is flexible or rubber, so it will be measured between two soft items, which is the nasal opening and the tragus of the ear. And then we will make lubrication and hold it with the channeled part at the end directed to the septum, nasal septum, and a slight twist right and left until it will be introduced. Nasopharyngeal shouldn't be used if there is suspicion of fracture base of the skull. And how you could suspect a fracture base of the skull? By rhinorrhea and otorrhea of CSF from mouth and nose, from nose and ear, and then raccoon eye or panda eye, which is the black eye, and battle sign, which is hemorrhage above the mastoid process behind the ear. Okay, these are the adjuncts of the airway. And lastly, the gift of the patient in the airway is oxygen mask. Put oxygen mask, either the airway is patent or obstructed, to make the patient relax and then make effort with respiration. After stabilization, you will go to. And here, as we mentioned before, in the local examination of any system, we do 4 items, which is inspection, palpation, percussion, auscultation. In the inspection, we come to the feet of the patient and be tangential at the same level of the chest, and then examine or look for the expansion of the chest and respiratory rate. This is by inspection, just by inspection. And then we will make palpation of the chest to confirm the chest expansion and examine if there is tender point. And what is the relation between tender point and toxic patient? Because this patient may have chest trauma. The toxic patient is not coming with pure toxicity. He is most commonly a cocktail of different things. So this toxic patient may have a quarrel, may have a trauma to the chest, may be fallen on the ground. So you should expect if there is, or exclude if there is chest trauma by palpation of the tender point of the chest. And when examining the chest, remember that we have 2 lungs, so the examination here will be by comparison between each point in the right side and the same point in the left side. Then we will make percussion, and percussion done by putting your middle finger of one hand in the intercostal space, and then by the middle finger of the other hand you will percuss it. And hear to the sound. And you should make this on you to know the normal from the abnormal. So with the normal sound, this is normal note. Sometimes you hear sound, high pitch of sound. This is the hyper resonance, and this is in pneumothorax. And sometimes you didn't hear sound, and this is dumbness of the chest in hemothorax. Um, Then lastly, by stethoscope, you will auscultate the chest, both at the apex of both lung to hear the air entry, and then all over the chest to hear any added or adventitious sound like wheezes, like crepitation, crackles, and so on. So this is the examination of the breathing, inspection, palpation, percussion, auscultation, and the gift of the patient in the breathing is to put pulse oximeter to assess the oxygen saturation, which is normally from 94 to 98 in normal patient, but if the patient with bronchial asthma or COPD, chronic obstructive lung disease, it will be from 88 to 92%, not more this. After stabilizing, we will go to C, and in circulation we will assess 3Ps: pulse, peripheral perfusion, and blood pressure. 3Ps. For the pulse, you will start by assessing the carotid pulsation at the same side of you, if it is felt or not, and what is the heart rate, and it is regular or not regular. And then with your left hand on the carotid pulse, put your right hand on the radial pulse of the same side to see if it is comparable to the central pulse or not. Is it possible to felt the carotid pulsation and not felt the peripheral pulsation in the same side? Yes, definitely. In shock state, if the patient is shocked and there is decrease in the blood pressure, you will not feel the pulse in the radial artery. Is it possible you don't feel the central pulse from start? Definitely. If the patient is cardiac arrest patient, you will not palpate the carotid pulse. Then move your hand from the carotid artery and put it on the radial pulse of the other side. So your hands here will be on the peripheral pulsation of the right and left hand, and see if they are equal to each other or not. Is it possible to find unequal pulsation, or you felt the radial pulse in one hand and didn't feel the radial pulse in the other hand? Definitely, it is possible. When? If you have a thrombus in this hand, or if the patient has a snake bite and make a tourniquet, so you didn't feel the pulse, or if there is wound, or if there is aortic dissection. All these possible causes of unequal peripheral pulse. So this is the first item in circulation to assess the pulse, and then you will measure the blood pressure using the sphygmomanometer, and lastly assessing the perfusion, the tissue perfusion. And the most rapid and easy way to assess peripheral perfusion is the capillary refill time. Capillary refill time, CRT. How do you assess capillary fill time? By pressing on the finger bed for 5 seconds and then remove your finger. If the color of the finger return within 2 seconds, this is normal perfusion. If it is delayed more than 2 seconds, so there is poor perfusion. Is there any other way to assess the perfusion? Yes, you could assess central perfusion by a conscious level of the patient. And if the patient has urinary cast, you can assess by measuring the urinary output or calculating the urinary output. So these are the 3 items for assessment of circulation, pulse, blood pressure, perfusion. And lastly, if you have a monitor, you should put the patient on monitor to assess ECG, and then put 2 wide bore cannulas or 2 IV access line, one in the right and one in the left, for drawing of the investigation, and then giving in the other line medications and fluid if the patient needs. Stabilization of the airway, breathing, circulation. So then we will move to this here in disability, we will assess the conscious level of the patient, the pupillary size, the random blood sugar. How to assess a conscious level? Yes, as we said before in the examination of coma, we have our mood scale. A, alert, B, responded to verbal, B, responded to pain, and U, unresponsive. Assess pupillary size by size of the pupils, reaction to light, and equality. Random blood sugar is normal from 70 up to 110. In healthy patients, in diabetic, maybe up to 200. And then if we have investigation in the C, we should assess the result of the drug chart or any result coming from the investigation. And we have exposure, and here we expose the patient in segmental way to look if there is any missed data by exposure of the chest for examination, and then cover it and expose the abdomen for examination and cover it, and then the upper limb and then the lower limb to preserve the dignity of the patient. After finishing the ABCDE approach, what should you do? You should reassess again. It is a dynamic process. You should consult for expert. If you reach a diagnosis by clinical examination and by taking history, and after investigation, you should consult as early as possible the expert. Here in the ABCD approach, you should assess, treat, and reassess if the intervention you make give a result or not. So this is the ABCD approach, and this is very, very important in the examination. Why do we do this approach? To collect data, then read a toxidrome. What are the toxidromes? Toxidromes are group of signs and symptoms related to certain groups of drugs. Let us say if you have a patient with tachycardia and hypertension and dilated pupils, what is the differential diagnosis of this patient? Yes, this patient could be sympathomimetic toxicity or anticholinergic toxicity. How you could differentiate between them? By examination. Yes, very easy to examine the pupils. If he has a dilated fixed pupil, so this is anticholinergic toxicity. If he has reactive pupils, there is sympathomimetic. Another examination by examining of the skin. If the skin is sweaty, this means this is toxicity by sympathomimetic, but if it is dry skin, dry as a bone, so this is anticholinergic effect. So we collect the group of drugs that has similar signs and symptoms in one group and call that a toxidrome. We have these toxidromes, we have sympathomimetics, we have cholinergic, anticholinergic, opiates, sedative, hypnotic, hallucinogen, and hypermetabolic. In each toxidrome, the examples of drugs under this toxidrome, the vital signs, the other finding in this. Okay, so this is to help you in differential diagnosis and to reach for diagnosis of which of these toxidromes. Last, doing history and clinical examination, the last item in the diagnosis is the investigation. And investigation here means that you can't reach a diagnosis by your hand and the stethoscope. So you have to withdraw samples or make the patient go to the X-ray or whatever to help you in the diagnosis. So these are the investigations. Because sometimes when I'm asking you what are the investigation you will do, someone of you will say blood pressure. Blood pressure is examination, not investigation. blood pressure you can do with your hand and your stethoscope and your sphygmomanometer. But when you cannot do ECG, so this is investigation. You cannot do X-ray with your hand, so this is investigation. You cannot do urine analysis, so this is investigation. So investigations are divided into two main types. We have toxicological investigations and we have routine investigation. And routine does not mean that you have to do all these investigations to each patient. No, you have to select the proper investigation or the specific investigation related to the patient or related to the condition. Okay, what are the types of routine investigation? We have lab investigation and radiological investigation. We have urine analysis, liver function, kidney function, complete blood count, CBC. We have ABG, arterial blood gases. We have ECG. We have radiological, for example, chest X-ray or abdominal X-ray. And in abdominal X-ray, we have a radio-opaque substance. And these are the radio-opaque medications: barium, enteric-coated tablet, tricyclic antidepressant, antihistaminic, chloral hydrate, heavy metals, iodide, phenothiazine, beta chips. Okay. The other type of investigation, which is toxicological investigation, by searching about the toxin in the blood or urine. And when we take urine sample for investigation, this is qualitative analysis, either positive or negative, and this is drug screening. When we take a blood sample for a quantitative analysis, and this therapeutic drug monitoring, we have the therapeutic level of the drug, and then we can diagnose if it is therapeutic or toxic dose, like salicylate, like paracetamol, digoxin, tricyclic antidepressant, thiophyllin, and so on. For ABG, we have to know some basics about ABG, arterial blood gases. This is one of the most important investigation you have to do to the patient. You withdraw arterial sample either from the radial artery or the femoral artery, and then you will have a paper like this with certain parameters. You have pH of the blood, you have partial pressure of CO2, you have oxygen saturation, and then bicarb. Okay, these are the normal value, and you should have know the normal value to know the abnormal. pH from 7.35 to 7.45. PCO2 from 35 to 45, bicarb from 22 to 26 milliequivalent. So if the pH in this range, it is normal pH. If it is above 7.45, this is called alkalemia, and if this is below 7.35, this is acidemia. So this is the pH. Above this will be alkalemia, not alkalosis, and below this will be acidemia. Acidosis and alkalosis is the process that leads to alkalemia and acidemia. Each one of this will be due to either respiratory or metabolic. If the change in the PCO2, so it is called respiratory acidemia or alkalemia. If the change will be in the bicarb, so it is called metabolic acidemia or alkalemia. And we have a rough equation which is called pH equal to bicarb divided by PCO2. So if the change in the PCO2, if the PCO2 increased, so we have CO2 retention, so this will affect the pH in inverse way. Okay, so the pH will be decreased. And if the PCO2 is decreased due to washing of the PCO2, the hyperventilation, so the pH will be increased. So there is inverse proportion between the pH and PCO2. But there is direct proportion between the pH and bicarb. When the bicarb increase, the pH will be increased. When the bicarb decrease, the pH will decrease. Okay, and this is, for example, if you have pH increased, okay, and BCO2 normal and bicarb increased, so this is metabolic alkalosis. If we have this picture, pH increase, BCO2 decrease, bicarb decrease. By the carb decrease, so this is respiratory, because when BCO2 decrease, the pH will be increased. So this is respiratory alkalosis, and the bicarb try to compensate by decrease to decrease the pH, but it is still high. So this is partial compensation. So if this is change here, if we have decrease in the pH, decrease in the bicarb, so this is metabolic acidemia, and the BCO2 tries by decrease to increase the pH. And you should know that respiratory compensation is more rapid than metabolic compensation. So if you have a change in all the three parameters, so this is compensation or uncompensation or whatever. If you have pH increased, alkalemia, and bicarb increased and CO2 decreased, so when the bicarb increase, the pH increase, so this is metabolic alkalosis. And when BCO2 decrease, the pH increased also. So this is mixed respiratory and metabolic alkalosis. When we have metabolic acidosis, you should calculate what is called anion gap. Anion gap equal to sodium minus chloride زائد bicarb plus bicarb. And this equation equal 12 plus or minus 4, or equal 10 plus or minus 2. So it is from 8 up to 12. This is the normal anion gap. Above this will be high anion gap. And we have high anion gap metabolic acidosis. When you find metabolic acidosis, you should calculate the anion gap. If you find high anion gap metabolic acidosis, the causes of high anion gap metabolic acidosis equal to mud diets: methanol, uremia, diabetic ketoacidosis, P, propylene glycol, I, iron, L, lactic acidosis, E, ethanol and ethylene glycol, and S, salicylate. So if you have patient with high anion gap metabolic acidosis, the toxic causes of this could be methanol, ethanol, ethylene glycol, propylene glycol, salicylate, and iron. This is the very basic information about the anion gap. So in this lecture, we talk about the definition of poison and toxin and how we can expose to toxicity, and the classification of the poison, factors affecting the severity of the poison, related to poison and related to the patient. And then we talk about diagnosis of toxic patients by history taking and clinical examination. And we talk about the ABCDE approach and toxidromes, and then lastly investigations either toxicological investigation, qualitative and quantitative, or routine investigation, laboratory and radiological. I hope that you understand this lecture, and we will continue in the next lecture, the treatment of toxic patients, inshallah. Thank you so much, and see you.